My name is Ursa Brown-Glaberman, breast medical oncology, and
I'm Karthik Giridhar, a breast medical oncologist at Mayo Clinic.
All right, well, we're going to start by first talking about decision-making in second-line landscape for metastatic hormone receptor-positive breast cancer, so an exciting area. First, what do you think about in this second-line setting?
Ursa, I think it's one of my favorite topics because it feels like right now it's the Wild West where we have so many different choices and difficulty knowing what's the best option at what moment in time.
I agree. I mean, I think the first line, we're really comfortable with those first 2 years on AI CDK4/6 inhibitor, great quality of life for patients, and we want something as good in the second line. And there's a lot coming, but we don't have a lot that's yet approved. So making that decision is tantalizing because I think there's a lot coming, but what? What?
Agreed.
Yeah.
Agreed. It feels like we have so many different possible options that are there, both biomarker selected and biomarker unselected, and figuring out the right treatment and sequences, I feel like that's really the challenge right now.
And so when you think about that second line setting, what are the top priorities for you?
So I'm an endocrine therapy maximizer. I like to get in 2, 3, sometimes 4 lines of endocrine therapy before I switch over to our ADCs or chemotherapy. And so I think we all pay so much attention to what do we think the disease status is in terms of, will another line of endocrine therapy offer benefit, or is now the time to pivot? So that's usually kind of my first branch point. And I'd say pretty small minority of the time do I not offer a second line endocrine therapy option. And then it's kind of how long was the benefit on first line, and what are the biomarkers originally, and as we are serially doing ctDNA to look for emergent resistant biomarkers, looking at the current profile to guide that next line.
I agree with you. Yeah, I mean, I think I'm with you. I'm an endocrine therapy maximizer, absolutely. I think that's how all of us were trained, and that's because quality of life is so good on endocrine therapy. And in metastatic breast cancer, quality of life is, from a patient perspective, really the most important, or as important almost as that PFS, right, that we're all looking at. So I think, to me, I maximize endocrine therapy because quality of life tends to be better for patients during that phase of their treatment. And so I think about quality of life, I think about side effects, with those options for my patients. Absolutely.
I think that it's thankfully a long journey, and we want to make it as manageable as possible for the people we take care of.
So in terms of other, you said, and I agree, we are endocrine therapy maximizers, right? What are the patients where you wouldn't feel like that was the right thing to do?
Yeah, I think it's the ones where we're seeing progression within 6 months of a CDK4/6 inhibitor, or there's early recurrence during a CDK4/6 inhibitor and we need a response. It's not often where I'm seeing that happen, but those are the times where we really need a response and you're questioning if endocrine therapy is going to attain that. Then that's the time where I'm looking to typically ADCs then to really jump out. Has that kind of been your
I agree. I mean,
well?
I think there's kind of two groups of patients. Those where you have some time to try a second or a third line, bone dominant disease, slower progression, slower pace of progression. You've been following them for many, many months, sometimes years. And then there's the group of patients who have a high burden of visceral disease who are going to drop off a cliff if that next line doesn't work, right? So to me, those are really two different groups of patients. And fortunately, most, I think, are in that earlier group. But to me, that's an important decision point.
Very much agreed.
Okay, so let's talk a little bit more about biomarker testing, another very, very hot topic. So what is your strategy for biomarker testing in metastatic hormone receptor positive metastatic disease?
So I think, right now, up front, to confirm recurrence, I'm usually, that's the time I'm getting a tissue biopsy. And nowadays, I've across the board shifted to sequencing blood and tissue up front on that specimen, just so I understand the existing mutations. And I think at progression, looking at doing ctDNA at that point in time, primarily to help figure out, are we seeing an emerging ESR1 mutation? Has there been any other acquired mutation that we didn't see before? But that's the main one that I'm looking for that might be new. And then kind of looking back to see, was there an ERB2 alteration? Making sure we've been thorough to make sure we know about PTEN and AKT alterations. And then I also do, for all of our metastatic patients, dedicated germline. Making sure we address our PALB2s, BRCA1, BRCA2s that are there to try to figure out what to do second
if they
line.
weren't tested early on,
If they weren't tested,
just confirming. I really think that is important. I agree with you. I mean, I think most of us, it is the standard of care now to biopsy confirm metastatic disease. I also agree with you on doing both tissue and liquid because you do see discrepancies and you find things you weren't expecting. I also think.
Did you do that off the bat right away, or with Inavo 120? Did that influence kind of selectively who you might do tissue and blood, or have you always been doing blood and tissue concurrently? I'm just curious how other people tend to practice.
I have leaned, tissue, I think, because that is the time when you get a fresh biopsy. So that's really the time you're going to have tissue often in these patients. So I've routinely been doing that, but I have added blood in because just of a few discrepancies. Many of the blood-based tests do look at germline findings. So you kind of are getting that double check on germline. And I think the other thing I'm looking for on that tissue-based testing is I have a few, very high TMB patients. I've caught some somatic, BRCA mutations, right? So there are some things you can catch that really might change what you do even in the first line.
I think, look, we did a little bit of work to look to see, can we take the ctDNA findings on germline as ground truth? And then the concern there is that most of the dedicated germline sequencing, they do orthogonal testing to capture those large gene rearrangements, which admittedly are only 10%.
Right, but you still might miss some.
And we saw that when we did it. And so I tend to
just do it, just dedicated.
Do it. Let's get the test.
If they haven't had it in the last 5 years or so, it's one of those check boxes. Have they had that done?
Exactly.
I'm with you. I think that's a really reasonable strategy. And I also think, and I think this is pretty standard. I think testing by ctDNA at each progression they're on.
Absolutely.
I think that's.
How are you choosing between? Do you have a preferred ctDNA assay? How are you choosing between our abundance of options?
So
right now?
it's interesting. I just recently joined a community practice. I was in a university setting before where we basically had one option, because the whole university committed to that.
Got it.
And now I'm in private practice and I can order whatever I want. And but I still do stick with. Once you learn an assay, you learn the report. You've got a good relationship with that company, you understand the technology. So I tend to stick with one company, just mostly out of familiarity, to be honest with you.
Got it. Yeah.
How about you?
I tend to dabble.
Do you?
They keep every time, every 6 months, there's some new component, and
some
sometimes
little nuance.
Sometimes I'm interested in one new feature or another new feature, and so I tend to rotate a little bit and then decide later what I'm most. But I think we're facing the same thing where we're wanting to kind of condense, because it's a lot of work for our team.
It is, for the staff. It is.
Yeah. So we're kind of in that phase where we're locking in what we're doing for blood.
For some consistency. And I think, honestly, you're right, for the staff, it's a huge difference. And so when you identify PIK3CA mutation, how does that change your treatment or your thoughts?
So I think if we're identifying it upfront in the first line, then I'm really sticking to that criteria for Inavo 120 to see if it was within or during adjuvant or within a year of finishing adjuvant endocrine therapy. But that changes now. My frontline management is, and then if I found it before and I see it again, then that definitely influences my selection of second line therapy.
Right.
And so they're paying attention to what specific alteration it is, realizing that I like to look at the variant allele fraction that's there and see, do I think it's the dominant clone in ctDNA? But I realize sometimes we overinterpret what we actually know when we make these decisions, but heavily influences the second line treatment option.
Yeah, I agree. I mean, there's a rare subset that Inavo is appropriate for, right? That's a triplet. It's more toxic, but for the right patient, certainly the comparator on that trial did very, very poorly, right? So I do agree. I think I use it, if you have someone where you're thinking about a PIK3CA inhibitor as their second line, that's your time to potentially optimize their metabolic disease, right? Their diabetes or pre-diabetes. Make sure they do have a PCP or an endocrinologist who's going to be ready to help you when you get there, right?
Absolutely.
So I think it's just helpful for planning. And I think patients find it reassuring if you can tell them, yeah, we've got a great second line option for you when you need it.
I very much echo those sentiments. It's nice to show, whenever we get the test results back, you can say, yep, we already know, planning ahead, we already know what we're thinking about doing. Yeah.
Great. Okay, so let's talk a little bit about TrueCap and PIK3CA altered disease. So when you think we talked a little bit about when to treat patients with PIK3CA alteration, but let's talk about that second line setting. What kind of stands out for you? Which are the patients you think might benefit the most?
So I feel like right now my struggle is we have so many different choices and options that are there. And if we look at some of the more recent phase 3 data, it's kind of trying to figure out what to use when. But if I look at the currently approved options that are there, our practice shifted pretty quickly towards Capivasertib once it got approved, mostly because of our the toxicity profile. So I think like right now, I'm making most of the decisions in the second line setting based on my perception of the toxicity profile rather than efficacy, because we have no head-to-head data yet. Right. But it's coming soon.
Exactly. Exciting. It's going to be an interesting ASCO. So
what did you end up doing, or how are you viewing?
So I was participated in lots of the alpelisib trials, so I had a lot of experience with that drug, and trying to convince a lot of community colleagues to give it a try, and it really did see the struggles, particularly in New Mexico. We have a large Hispanic population, a large underserved population. Diabetes is very frequent, and so there was real struggles with that. So I agree with you. I think that one of the advantages of Capivasertib certainly was the lower rate of hyperglycemia. And so I think also our practice almost universally has switched to using Capivasertib for PIK3CA altered metastatic breast cancer.
What do you make of the Evora data and the control arm? Because to me, what's very interesting is, we went from being so molecularly targeted to now everolimus is making a little comeback.
Yeah.
And then we have these PAM inhibitors in development. And, I feel this yin and yang tug between everything being so molecular, and then we step back and we're like, sometimes we feel like we don't quite know yet what to hit when.
I agree. I think it really is interesting. I mean, even the Capivasertib trials, right? They had a large, biomarker unselected population, right? And they saw a benefit. I think it points out that endocrine resistance is complex, right? There's a lot of interplay there. I think it's cleaner to think about a mutant population, and we see the stronger signal there, right, across these studies. I think the Evora data is very interesting. I mean, again, I'm somebody who used a lot of everolimus in my career, but that's also a tough drug, and I do think that we're going to have better options moving forward. I do.
So it sounds like, just like for me, it hasn't changed what you're doing. You still, if you have a biomarker, we're going to use it, even though the PFS in both contexts are the same, or based on the tolerability context. Realizing we should be cautious as always about all these cross-trial comparisons.
Which is hard not to do in this era, for sure. And I think what I like about Capivasertib personally is when I relook at that data and I look at what the toxicity profile was, and it fits so well with my experience, right? A lot of grade 1 and 2 diarrhea. You have to be able to, anticipate that. You have to have patients be ready, talk to them about diet, and having loperamide on hand, and all of the things that you need to do to mitigate that. But it really is true to what they saw in the trial in my clinical practice.
I echo that. Month 1, proactively engaging, and I'm so happy we have a clinical pharmacist who really helps manage this, checks in every week at that day 3-4, helps us figure out where we're doing our blue, but it's like with that proactive management, it goes well.
So other than managing diarrhea, what other things do you use prophylactically?
I adopt the cetirizine. I start doing the once a day 10 milligrams as prophylaxis. I think that even though there's not as much data based on the pathway and class effect, it's we've been doing that regularly. Have you been doing the same?
I do. I mean, it's a benign treatment. Many patients are already on medicines like cetirizine, and I have seen patients with rash, and so certainly if it can prevent that, it's again, this quality of life is super important.
Agreed. I think patients that I worry about hyperglycemia, like how you mentioned how you're preparing them ahead of time, then kind of if I'm seeing elevated fasting glucose, kind of borderline A1C, kind of the gestaltiness, where we're a little worried, then I'll bring up the idea of doing metformin metformin.
Yeah.
Typically, I still do that first. I've not jumped right to the SGLT2s. What have you ended up
Very
doing?
similarly. I mean, I think I do see it as a time, mostly to make sure, honestly, again, I work with an underserved population, want to make sure they're plugged in with a PCP at minimum, in case I need some backup there. Diabetes has changed a lot since I was a resident, so I want some help if I need it. So just plugging patients in with a PCP. Sometimes I start patients on metformin, which low-dose metformin is also very well tolerated. So it's very similar.
Are you arranging for home glucometer testing, or is it pretty easy for the people in your area to get the labs, or how have you been handling
so
that
that's a
piece?
good question. It was interesting you mentioned about having a clinical pharmacist. So when I was in university-based practice, we did have better pharmacy support. I think in a private practice clinic, you have less support in that way. And so I rely a lot on nurse practitioners. I think nurse practitioners are incredibly helpful in terms of symptom management. I mean, they are the experts, honestly, in symptom management. And so I think, putting some time into helping to educate your support staff, your nurses and nurse practitioners about what needs to be monitored and what are the symptoms to expect, and some basic strategies goes a long way for the patients and for you as a clinician, right?
Very much agreed.
Yeah.
And it's,
We, so mostly, again, it's interesting. You would think in a very rural state where patients live far away and have that they would use some of those home monitoring. They're so used to getting their health care by driving to you that even, during COVID, we did very few virtual visits. Everyone thought we would, and we don't, because there's a huge technology barrier. So actually, a lot of people come into clinic. They're more comfortable with that. It's the sort of familiar pattern.
Got it. Okay.
Is there a patient, so we talked about, I think both of us are using, Capivasertib routinely in the PIK3CA mutant population in the second line setting. Is there a group that even within that setting you think, this is the right patient or this is the wrong patient?
That's a good question. I don't know if I think the only patients that I think it's not the right move necessarily might be one if I just think they're just too many comorbidities, medically frail. I get, I'm worried about just anything that might induce hyperglycemia, right? And it's just like I mean, we push the boundaries, right? We've given it to people who are on insulin and things like that, right? So it's even that. For me, everything becomes a soft, relatively soft a relatively soft issue. But then I think the only group that I truly might not is if I need a response, and I don't think another line of endocrine therapy. But we kind of touched on that before.
Sure.
What about for you? Do you feel differently? Is there a group that you would explicitly say no to outside of kind of like fitness, kind of gestaltiness?
Yeah, I think you're right. I mean, I think there's some patients where I do worry either that they are advanced enough in their diabetes, or I've had some patients who are right on the borderline in terms of renal function, where that diarrhea really could make a difference for that person. I do also think the schedule, 4 days on, 3 days off, that is complex for some patients, and so patients with very poor support at home or low medical literacy, that can be a challenge. I don't think it's insurmountable, but those are all things I think about. But I'm with you. I don't think that there's a group I would hands down say that I would exclude. It sounds like you are already really not waiting till not using oral SERD or something first. So you don't save this for third line, I guess is what I'm saying.
I mean, no, there's plenty of times where I do. It's just I don't think any of us have been super excited about SERD monotherapy, and so it's kind of. But there are duration of or subset of patients that gain benefit from that. So if I see really slowly progressing disease, and I just want to change the backbone, continue CDK, I'll use it third line. So I don't. But you're right. I guess that does make sense. So sometimes I'm not necessarily using it second line, but I'll use it eventually, and it's just kind of figuring out which one to use when. I don't know if any of us truly know.
I agree
which
with
way
you.
To go.
It has more toxicity than certainly an oral SERD, and so I prefer to use it when a patient's performance status is still better. I don't want to wait too long. So I tend to use it probably a little bit earlier, I would say. But I do switch the backbone sometimes and continue CDK4/6, which is sort of like that. That's a strategy, I think, a lot. And there's more and more data, to look at that as a strategy. So.
I agree.
Okay, so we talked a little bit about side effects and preparing patients. So what are the things, the highlights you talk to patients about in terms of what to expect side effect wise?
So I think this is one of the times where we get more into the dietary management. I feel like so many patients are willing to be proactive and are like, what are some of the things I can do? So actually going into some of the reducing carbohydrate intake and whatnot can actually help with some of the hyperglycemia management. And I think one of the meds that we give, but we don't prophylax with, is loperamide, and just making sure people know it's okay to use, right? Like, if you're having ever more than 4 bowel movements in a day, call us, right? Like, those are the things we can manage over the phone, and just the early intervention piece. So I think a lot on the hyperglycemia and the diarrhea management, and then the rash that we chatted about. I think that's probably the bulk. What am I missing here? What else?
No, very similarly. I mean, I talk to people. I really think just encouraging loperamide use. I had a patient who, she, particularly if she was going to be out, away from her house for half the day or the full day, right? Just prophylactically take some Imodium before you go. That's okay to do. And so just coaching them, and I think that they figure out their pattern, and they do get those days off, which I think is helpful. But supporting them through, especially those first month or two, is definitely when I think, more frequent clinic visits, really making sure you do some symptom check visits is really critical.
Yep, and I think that's, again, like, I feel so lucky to have our pharmacist do those weekly checks. It makes it very. So what cadence are you actually seeing people back, or how do you handle that?
So usually I see people back within the first 2 weeks of starting. That's kind of my routine, myself as a nurse practitioner. And then often I really will keep a pretty close eye on people for those first 2 months. Just making sure they have a low threshold to check in with us. Obviously checking their labs. I felt like when, certainly when alpelisib was the option, I did see a lot of hesitancy from, my colleagues all over in terms of using that drug, because once they had a bad experience and were burned with it, they were really unlikely to try it again. If you have a patient admitted to the hospital for DK, right, you're going to be hesitant the next time you use that drug. I see less of that with Capivasertib, but and so I really do encourage people to try it. I think for those patients it works for, they do. You see some really gratifying extended time period on endocrine therapy where patients' quality of life is excellent. So I really encourage trying it. So, and I think mostly I talk about the pointers we just mentioned. The side effect profile is what you saw in the trial. You're going to see low-grade diarrhea, keep an eye on hyperglycemia, and prophylax for rash. That's kind of my advice. Is there any other sort of practical tips or what would you tell a physician who is hesitant to try Capivasertib?
I think probably making sure just to understand why. I think by now most oncologists that see patients with breast cancer have likely used it and got some sense by this point in time. And so, I think we are at least seeing, very similar to what you've said, that the rates of stopping based on side effects seem low. If you can get through month 1, I feel like we're in a good spot with patients. So that first month, just being really proactive about management, and then that early check-ins can be helping, and making sure people are prophylaxing as needed to help address things.
Yeah, I agree. We talked a little bit about sequencing. I do think it's hard because there are a lot of exciting new data, right? There are combinations that are coming, but none of them are approved. So what, when you think about sequencing in the future, what are you excited about? What do you think that landscape might look like?
I think one of the things I'm really excited about is that ARPA-H TBCRC study, EVOLVE, where the whole goal is to use biomarkers beyond our conventional sequencing, integrating imaging, and then working with these different academic centers to help do this iterative evolutionary trial to help figure out what to do second and third line and what to use where. But I think that's still going to take quite a while to get an answer. In the meantime, we're going to have several other phase 3s report out, and we're going to see just tomorrow what's going to happen with the PIK3CA mutant cohorts and gedatolisib, and I imagine that approval is coming soon.
I think so.
I think it's exciting to see some of these head-to-head studies with the allosteric inhibitors that are coming into play for PIK3CA. I think those are very interesting to see. And then, we're seeing mutant-specific inhibitors, so it's so different, like everything that's coming. So a lot of excitement.
I think so too. I think, and I think that is when people ask me why I went into oncology. It's because I knew in my lifetime things would change dramatically, and breast cancer even more so. Right? It's just there's truly is just a number of good drugs coming down the line, and we're not going to have trials to address the sequencing question, right? So I think what you were getting at, I think people are trying to think about trial designs that might address that even in small sets of patients. But that gets into kind of real world data, I think. And what's your thoughts about real world data and how to use that in the absence of clinical trial data?
No, it helps fill in gaps and help confirm or better clarify at a larger scale what sequencing might make sense. And I don't know, I think it's with how with Capivasertib in particular, it was reassuring to see some of the real world data to show that the post-CDK and larger cohorts and whatnot are all very similar to what we thought. Same with like some of our SERDs and whatnot, seeing that the real world data is representative of what we saw in the trials.
Yeah.
So I think it confirms some. I don't know if I've seen real world data yet dramatically shift some of my practice. I think it informs even some of my ADC sequencing. How do we counsel patients when there's really no trial data to support it? What's caught your eye?
I totally agree with you. I mean, I think it's quite reassuring when you see it support what you saw in a trial, particularly in some of those trials where perhaps, as you mentioned, like with Capivasertib, almost all patients have received a first-line CDK4/6 inhibitor, right? So that more reflect what is the standard of care in this country. That is really helpful to see. I agree. I haven't yet seen a situation where I felt compelled to use real-world data to change my practice. But I do think we're going to have to get there likely in a bunch of settings in breast cancer, right? Especially as MRD testing improves, as the technology for molecular testing is going to outpace us by leagues, right? We're not going to ever catch up with using only standard clinical trials. So I think we're going to have to start to think about that as providers.
I wholeheartedly agree, and I think we have to rethink how we do more pragmatic trials. And it's like we kind of tease saying we've got 3 sites, Mayo, Minnesota, Florida, Arizona. We'll just say each site do one, and then we've got a stepwise randomized trial.
I like that.
And then we can, in 2 years answer the question. But it's just like, we need better ways to do this, and that we can capture data beyond claims data and really have start and end dates and get a better insights on toxicity. And so as our ability to extract data out of healthcare system grows, I really do hope we'll get to a spot where some of these sequencing questions can get answered in a more meaningful way.
I'm with you, and I think we'll get there. I actually do believe it. I think, with enough places on the same EMR, that's capturing very similar metrics, I think we will get there.
Agreed.
So we talked about, primarily selecting the use of Capivasertib just based on side effect profiles, but there are some differences in terms of the patients included on those trial populations and some of them other key drivers in those pathways, including AKT. What are your thoughts about that?
Well, I think, Capivasertib is the only drug that will be there if somebody has a PTEN loss or an AKT activating alteration. I think those represented a smaller portion of the patients on each trials, but it's definitely something we should pay attention to. And, as we step back and reflect on the entire pathway, each drug now, we have so many drugs hitting different parts of this. And with the alpelisib being isosome specific, but still is an orthosteric inhibitor. And so we see a lot of the on-target effect with hyperglycemia. And so it's interesting as we get some of these allosteric and the allosteric inhibitors that are coming into place, and hopefully we get to see either higher efficacy or a better side effect profile as we get a little bit more specific with the pathway.
No, I just think, I agree. I think some of these early phase drugs that we're starting to see that are much more specific for the mutations, you really do see a better side effect profile. I think it is important when you look at those molecular reports to not forget about, the AKT and PTEN subsets, right? The benefit was across the all 3 populations, a strong efficacy.
How do you feel about PTEN testing in ctDNA? And do you have any concerns with calls of loss in the context of ctDNA. I think inactivating mutations I feel comfortable with. Copy number loss, it gets very finicky, and some assays do a lot more with copy number calling, and some do a little bit, like those thresholds get varied. Do you feel any particular way of PTEN loss in the context of ctDNA testing?
That's interesting. I hadn't thought about that specifically. I mean, I think ctDNA testing broadly, as you said, looking at that tumor fraction, are you really looking at something that's real? Yeah. I mean, I think that's, to me, the hard part is as you pick up some signals, are those real signals? And I think that's why I do love it if I have tissue to sort of help look at some of those questions.
And if you've used a PIK3CA inhibitor, are you testing post-progression to see if, because we know one of the acquired resistance mechanisms to PIK3CA is PTEN loss. And so in that situation, would you then ever think of sequencing and utilize an AKT inhibitor afterwards?
That is really interesting. I haven't done that, but it's intriguing to think about. I mean, I think that will be part of the sequencing question, right? As we get more drugs and thinking about resistance mechanisms, what does that, next iteration, post-progression look like?
I've done it a handful of times, and it's, we can still see benefit of targeting the pathway. And I think this just speaks to exactly what you're saying. We don't quite know what, when, or who might gain from hitting a different protein in that pathway.
Yeah, resistance is complex. I think we all pretend we can understand endocrine resistance in breast cancer, but
Agreed.
Yeah. I don't think we're there yet. All right. Well, thank you very much. This was a wonderful conversation. Appreciate it.
Thank you for having me. Nice chatting.